Okay. Ladies and gentlemen, dear colleagues, we should proceed with the next part of the session. Congratulations to organizing committee choosing such a very important topic, calcified lesions. It's very interesting, and still I believe that coronary calcification is one of the biggest enemies of interventional cardiology. So I agree with Patrick Service about that. And I have pleasure to give the podium to Dr. Nair for his lecture, Non-Compliant Cutting and Scoring Balloons, the good old stuff in treating calcified coronary lesions. At least for me, the good is the main word, not old. Please.
Okay. Yeah, thank you very much for the introduction, and thank you for the organizers for inviting me again. And I'm here after 3 years. I haven't been to the BBC, but I've been to other meetings. It's indeed a pleasure to be back in Sofia. So we heard in the earlier sessions about diagnosing coronary calcification and the importance of coronary calcification. And I think this afternoon session is mostly on how we manage patients that have coronary calcification. Now, it does say good old stuff, but I beg to differ on the old because there are some newer balloons that actually have come out after some of the older atherectomy devices. So good stuff. My discussion is going to be around different kinds of balloons that we use to prepare the coronary vasculature, the calcified coronary vasculature, for the placement of stents. Remember, in a majority of cases today, we are preparing the coronary lesions to place stents. So any device that we use to prepare the vessel can be called plaque modifiers. Okay. So what are the good old stuff equipment that I'm going to discuss? We will talk very briefly about non-compliant balloons, the newer ultra-high pressure balloons that I have no experience with, cutting balloons and scoring balloons. And that's where I will stop because that's my job. And the rest of the folks will discuss other kinds of plaque modifiers. So everybody is familiar with non-compliant balloons, and the two cartoons depict the two kinds of balloons that we use, the semi-compliant balloons that are very flexible, extremely low profile, available in many diameter sizes. We use these balloons to pre-dilate lesions. The way the plastic balloon is constructed, they are unable to provide very high pressures. They do grow at high pressures, so generally not used to treat calcific lesions, but just as a basis to differentiate the different kinds of balloon. I brought an example of semi-compliant balloons. By and large, if you want to treat a calcific lesion effectively with a balloon, you have to use a non-compliant balloon. Why is it called non-compliant? A very simple answer. It tends not to grow as much. Of course, even non-compliant balloons grow to a certain degree, so that if you go to very high pressures, depending on the manufacturer, they will all grow to a certain degree. So non-compliant, yes, but they will grow to a certain degree. They are a little less flexible than the semi-compliant balloons, a little more bulky, so harder to cross some lesions. But if you do want to effectively treat some non-dilatable lesions, a non-compliant balloon can be used. Now, this is very often used as a first step in many, many procedures because experienced operators will say if you use the right diameter balloon, and if you see that the balloon is fully dilated at a reasonable atmosphere, then that lesion is being well prepared for a stent, because the stent will be the appropriate size and the lesion is well enough dilated, and you can put a stent and there will not be under expansion of the stent. So this is very often the first device that is used. So when can it be used? Well, if you see mild to moderate calcification, and as has been elegantly discussed before, there are many ways to diagnose calcification in vessels. Now, why do I put mild to moderate in quote unquotes? Because we really don't know what mild to moderate is without doing intravascular imaging, because the only way to detect is by non-invasive testing, like was mentioned before, a CT scan or fluoroscopy angiography, where you see calcific silhouetted vessels. So, and in the eye of one beholder, it's severe. In some people's eyes, it is mild. In the other people's eye, it is moderate. So mild to moderate calcification, okay, but we really don't know what that is. But if you do intravascular imaging, either OCT or ultrasound, we may be able, as was mentioned before by Kiko, that we may be able to determine the extent of calcification. So non-compliant balloons, by and large, may work in thin calcific arcs of less than 270 or so. What this will really do is it's not going to fracture effectively the calcium. It will dilate the non-calcific element. And therein lies a problem, because if you were to use a large enough balloon and at high pressures, it is possible that you will dissect the dilatable, the more flexible portion of the concentric vessel, not do anything to the calcium. And perforations, dissection more often, are very possible. And these tend to occur at the junction of the calcific arc and the non-calcified fatty plaque. That junction may rupture. So one has to be very, very careful in pre-dilating calcific lesions at very high atmospheres with non-compliant balloons. And the pressure at the calcific level is a certain degree. The balloon will not stretch, so most of the pressure then is exerted to the non-dilatable portion, and that's the reason for the dissection and perforation. And when it occurs is completely unpredictable. And so there is a certain degree of anxiety when the balloon comes down and we do an angiogram, especially if you have gone to high atmospheres. Have I dissected or perforated the vessel? But there are certain advantages in using a non-compliant balloon to dilate calcific lesions. The fact is that you don't need any special equipment. Anybody that does interventional cardiology knows how to prepare and use a non-compliant balloon. So it's very easy. It is inexpensive, especially when you are fiscally responsible. It is an inexpensive device to use. And as compared to the other devices that I'm going to talk about, it is relatively low profile, so it can cross very tight calcific lesions. Now, it can often be tried as a first step. So experienced operators, as I said earlier, will use the appropriate size balloon, dilate it to a certain degree, and see if there is the dog bone effect or has the waist disappeared. Usually when the waist disappears, you know that you've taken care of that non-dilatable lesion. Very often it's because the calcium tends to be mild or moderate. It's not a circumferential calcific plaque. It tends to be thin, so this vessel can be dilated, and you've prepared the lesion for a stent. So that's one of the uses of a non-compliant balloon. Now, what happens if the lesion does not respond to a non-compliant balloon? And how do you know that? You have a persistent waist, and you are a little hesitant to go to very high atmospheres because of the problems that I mentioned that could happen, dissection and perforation. So there are these super high pressure balloons that can go up to over 35 atmospheres. And these balloons are made with 2 layers, so they do not expand at all at that kind of pressure. And I have no experience because the FDA has just released this balloon. I think it's available in Europe, and I'm willing to listen to anybody's comments on how and what their experience has been with these high-pressure balloons. There are no formal studies. There are case reports that I have read about this. And apparently, the perforation and dissection rates are low, and non-dilatable lesions sometimes do respond very well to high-pressure balloons. And stents can be successfully expanded and placed after treatment with these ultra-high-pressure balloons. Again, this is very user-friendly because it is prepped like any balloon. But Professor Galeb day before said it's a very bulky device. I have frankly don't know about it. So these are the characteristics of these ultra-high-pressure balloons. They will not grow, so they apply uniform pressure. We and others have very limited experience. It can be used for non-dilatable lesions and maybe again for mild to moderate calcification. I don't know what kind of lesions you would choose this in, but maybe for mild to moderate. Again, crossing profile is a little large, so you may have to pre-dilate the vessel to prepare it. Moving on to other devices that are relatively new over the last 10 to 12 years. These are balloons that have various kinds of scoring or cutting mechanisms around them. This is an angioscope balloon from Philips. This has a simple wire that's wrapped around this balloon. And when this balloon is inflated, supposedly this wire is supposed to cut through the intima, cut through the calcific tissue, and create controlled dissection. So the rates of dissection and perforation should be low. The crossing profile of this is higher than any other plastic balloon, so you may not be able to get it through tortuous lesions, very severe lesions, and sometimes you have to pre-prepare the lesion with small semi-compliant balloons and then try to put this, so double balloon strategy, just to get the lesion appropriately prepared for a stent. So that's the angioscope balloon. Another kind of balloon is the chocolate balloon catheter. Again, it's a balloon that has wire wrapping around it. So this is more flexible than the previous one. I don't know how effective that is. None of these devices have had any kind of randomized trials done to look at the effectiveness. All that we know is from registry and prospective, not trials, prospective studies, is that certain lesions do respond to this. Stents can be placed, and overall results over 1 year and 2 years after balloons with cutting devices have been used, coring devices have been used, stents are placed, patients tend to do well. They don't slip, so as a segue, they can be used in stent restenosis because these balloons will stay within the stent. So, this one was one of the first ones to use. It's the Wolverine cutting balloon that's from Boston Scientific. They have improved the quality of the balloon, so they are a little more flexible and can cross lesions which they otherwise couldn't. What this has are 3 blades that are folded into the balloon, so when you inflate the balloon, these blades will pop out and supposedly cut the lesion. So of all the 3 balloons that I just mentioned, this is the stiffest and has the hardest time crossing lesions, but probably intuitively makes sense that this works best in terms of trying to cut fibrocalcific plaques. Okay, so to conclude with these devices, because my talk is very short because this is all that is known, that these balloons probably work for calcific arcs that are less than 270 degrees and thin calcific arcs too. So mild calcification, thin plaques, not circumferential, probably less than 270, maybe more 180, and these may fracture with the cutting balloons. It will not probably cause calcific plaque fracture, but may stretch the non-dilatable fibrotic element of the vessel. and you can use these without using high pressure, so less danger of perforation and dissection. Will not slip, as I mentioned, but they do have high profile, so it is hard to cross tortuous vessels, hard to cross tight lesions, so you may have to pre-dilate a certain segment to allow these balloons to cross. There are very limited publications, as I mentioned. They allow for better stent expansion, but whether it reduces restenosis or not, we really don't know. So how do you choose any one of these balloons? Because crossing profile and flexibility are variable, so it depends on what balloons you have in the lab. I meant these cutting or scoring balloons, and what experience you have with any one of them, and that's how you use them. The degree of plaque disruption is really not known. If you do OCT or IVUS, you might see some fracture, but I don't know if it is consistently seen, and is it the same appearance with each one of these balloons. It's really unknown. The last thing I mentioned, paradox, is that the most flexible balloon, which has that wire wrapping, is probably the least effective, whereas the Wolverine balloon that has these knives, probably the most effective, but are the least flexible, so harder to get to the lesion. So as a final thing, I'll present a case to illustrate some points. So this was a patient who was hypertension, hyperlipidemia, diabetes, end-stage renal disease, on hemodialysis, and also COPD. And this was the timeline of what happened. She presented to the emergency department with shortness of breath, had COVID, and was sent home, worsening shortness of breath, now with electrocardiographic changes, comes in and has elevated biomarkers. And she has a left heart cath. I will show you the angiography. And based on that, you will see she was referred to our surgical colleagues. She got worse, was intubated, and hemodynamic unstable, so a balloon pump was placed. So this is the angiogram. I don't know how well it projects. I don't have a pointer, but you can see before the contrast is even injected, you can see that there is. I do want to play this again. Okay, it doesn't play, but I'll move this mouse. You can see even before the contrast is injected that there is a significant degree of coronary silhouette that is seen, that's with calcification. And in this particular projection, you suspect that there is significant left main disease. Okay, it's running now. This is another projection. Again, you can see the severe degree of calcification that is seen in the left antidescending and in the left main. And there is not severe? Okay. To some people, it is not that much, but it seemed quite severe. And with this, she was obviously very sick, had COVID, poor thing. This was a right heart catheterization. You really don't need to know that. And so this was done by one of my colleagues, and the fellow presented this to me, and I said, hey, let me steal this case from you, and I can present it, because there is a problem, and I didn't create it. So because of the calcification and because of the severe nature of the left main coronary disease, they estimated that this would require some kind of plaque modification. Then they chose rotational atherectomy. It was easily crossed with the wire, and they used a 175 burr to modify this plaque. No imaging yet. And after that was done, they put a high-definition IVUS catheter from Boston Scientific to look at what the vessel looked like. This is often done in left main cases to determine the extent that you need to stent, what is the diameter of the LAD, what is the diameter of the left main. So that this was done. And this is the guide catheter. And you can see that there is significant degree of calcification, and what is important is that you can see that there has been fracture of that calcific element. Even though it's not 360, you can see there is disruption of the calcific rind, if you will. See, there is a lot of echo density suggesting calcification, and this is a piece of calcium that's broken off. There is a gap here. But based on this, they felt, well, there wasn't that some more work could be done, so they used a cutting balloon. This was my point, that is sometimes you use a hybrid approach. So they used a cutting balloon to get even better results, so that you would be able to put a stent in without having much trouble, because there is calcification, tight left main. You don't want to spend too much time with the balloon in there. So if you create a passage, you can put the stent in quickly. So this is what happened. I don't know if you can appreciate this. So again, you can see the calcific element. And what is important to see is that from 3 o'clock to about 6 o'clock, you can see, and look at this appearance from 3 o'clock to 9 o'clock. So it went by fast. But here you can see that there is a hunk of calcium that is moving, that is mobile. So whereas that wasn't seen with rotational atherectomy following the use of a cutting balloon, there has been further disruption of that calcific element. And I don't know if you realize that there is a large intramural hematoma that is extending from 3 to 9. This is the left main. This is here is that hematoma. Do you see that? So that's a large hematoma that occurred, but not a big deal. So, you plaque modified, you ballooned it, you see hematomas dissection. In the old days with balloon angioplasty, you worried, but these days with the stent, you don't worry. So they went ahead and put a stent in. And following the stent, they did an angiogram thinking that now it is ready to send the patient home. Now you see a large dissection in the left circumflex. So when you have a dissection in the left main, obviously it can extend into other vessels. So this was a large dissection in the left circumflex. You can see it, right? Fortunately, it's not causing closure of the vessel. There is still adequate flow. So they quickly put a wire down. They were lucky enough to use a wire down by using a dual lumen catheter. After having done that, the LAD was already stented. They did a tap on the, and this is all pretty routine. They did a tap, and then this was the end result. So my point in presenting this case, we don't even have to look at that, is to underline the importance of imaging. Now, they could have seen the calcific element, that the plaque was already fractured. There were gaps in the circumference of the calcific element. Maybe you could have stopped there and put a stent in, but instead they wanted to do more. The enemy of good is better. Sometimes they use a cutting balloon. Perhaps those cutting elements went through that calcific cracks and cracked the tissue beyond the calcific element. Maybe that is what caused the hematoma, which then extended down the circumflex vessel. So treating calcific lesions is not sometimes a piece of cake. You get unanticipated complications. This is what has been well known and has been mentioned before, that when you treat calcific lesions, there's a higher rate of complications, a higher rate of restenosis. And this is an example as to how when you treat, everybody treats patients like this all the time. When you treat patients like this, you can get such complications. So look out for calcific lesions, that they could create some trouble sometimes. This is also an example as to where a hybrid approach was used. They used rotational atherectomy. The vessel is very large. They wanted to have more effective plaque modification. They used a cutting balloon. They used a larger than necessary cutting balloon, perhaps. That resulted in a dissection that extended into the circumflex, which really did not have much of a problem. It was going to be a single crossover stent strategy. They had to convert it into a tap, but that was all done successfully. You have to be careful, of course, how you wire the circumflex, because you could end up in a dissection plane, but they were lucky enough to end up in the true lumen. And again, it's an example of a complication of a PCI lesion. So in conclusion, balloons of varying types have a limited role, I think, to play in treating calcified coronary lesions, and it depends very much on the calcium characteristics. And this can be determined by CT scan, as was mentioned, can be determined by fluoroscopy and angiography when you see a lot of calcification that generally raises your inclination to use plaque modifiers such as atherectomy or cutting balloons or laser sometimes. So you're already prepared and already thinking that you may have to modify this plaque. If you do intravascular imaging after you pre-dilate the lesion, you can perhaps predict what device you have to use. So for example, if you see very thick calcium, if you see an arc of calcium that's more than 270, you might think, well, a balloon is not going to work. Let's stay away from that. Let's use orbital atherectomy or rotational atherectomy, modify the plaque, and then balloon, and then stent. If you just use the balloon, for example, but you don't, the advantage is, of course, you don't need any additional training. It's inexpensive, and if it does work, then you're home free. And of course, it can be used following rotational atherectomy in a hybrid fashion. However, the evidence to support the use of any one of these devices, including the new ultra-high pressure balloon, is extremely sparse, and most of it depends on the operator's experience and expertise as to when to choose what. The one caveat I will always mention is that if it doesn't work, you have to be prepared to use an atherectomy device, either rotational or orbital atherectomy, because you cannot go in, try to cut, it doesn't work, and then you put a stent in, then you will have what is called stent regret, because the stent will not fully expand, and that is a nidus for both in-stent thrombosis and restenosis. Thank you for your attention.
Thank you, Dr. Nair, for your excellent lecture and very clear messages. Now the lecture is open for discussion, for comments.
I cannot agree more with these conclusions. It is success in using balloon-based strategies in calcified lesions is not always predictable, but this is the first device that is often used, especially with limited experience. That's the first attempt that you make. And it's very nice, the message that you conveyed, that just beware that this is not a solution for all calcified lesions, and if you can tailor it, perhaps you can get the best out of this technology, which is anyhow useful in certain calcified lesions, but not in all of them. So I think that was the best take I could get myself.
I'm glad you got my message.
Actually, I remember it was 23 years ago. My God, how a long time was it ago that the first cutting balloon came to Bulgaria, for example, from Japan. The main purpose to use it was the coronary restenosis, instant restenosis.
Correct.
Was not the calcium. Even the calcium was a little bit contraindication for using that, but still it has place in some cases.
I have a question regarding the usage of cutting balloons, probably to both of you. Just do you, because in severe calcification, the cutting balloon is probably, at least it is still written that it is contraindicated.
Yeah.
What is your opinion from practical point and personal experience? Because if started with feelings this early morning, and probably we have to continue a little bit more.
I don't think it is contraindicated. It probably will not work. More importantly, if they're severely calcified and stenotic, it will not go through even.
Yeah, but if it goes, there was the contraindication is because of the possibility to stack some of the blades into the calcium and to disarrange the balloon. Dr. Barbato, what do you think?
Well, he said it all, actually. He mentioned it very well. This cutting balloon, if it is not properly used, it would dilate in the points of minor resistance within the coronary segment. not where you have the biggest bunch of calcium. It's a combination of factors. Akiko mentioned also the location of the lesion is important. Proximal segments as compared to distal segments. You know, cutting balloon would go in proximal segments, while scoring balloon perhaps would have better crossing profile in mid to distal segments. This is something you have to factor in. The anatomy of the calcified lesion is important. Superficial calcification, perhaps thin calcium, not to 360 degree would work. But angiography cannot let you predict what is the right setting, where to use this or the other. That's why intravascular imaging, I think, the threshold to use intravascular imaging should be lowered down and guide us on the best device to select. And by the way, in my lecture, I would provide some practical guidance on this.
So I have there is one interesting concept that's been raised is to use a cutting balloon in calcific lesion followed by drug-eluting balloons. There's a trial, I forget the acronym, that is being used to see whether you can get away without stents in diffusely calcified vessels. Do you have any experience with we don't
Not
have
myself, but I think Akiko mentioned this among the lines, saying calcified nodules, perhaps no stent is a solution. Perhaps drug-eluting balloon could be there a solution, I don't know. But I personally don't have experience with that.
Just one remark. You have to be aware that possibilities of new computed tomography assessment will give us many information about the calcium location, length, depth, all of the things, and it's a matter of time to get softwares with usage of artificial intelligence to plan the procedures based on that, and that will come for sure.
I'm a little bit less confident than you are. As much as I like CT, I like it very much for procedural planning, but the way I see it today is as a tool to stimulate more and more the use of intravascular imaging to refine the strategy on the table. In isolation, CT planned or CT guided PCI is a dream for the time being. We have to admit that there is still the blooming artifact that doesn't really disclose us where the calcium is located, at which layer of the coronary segment, whether it is really thick or not thick. So I'm not sure we can see it all from CT.
You have to remember that 10 years ago, calcification was a kind of contraindication for CT.
Sure.
Right now, we are able to collect a lot of data.
Even
And of
stents,
course,
we can see through
yes,
stents nowadays.
yeah. So it's a matter of development of technology, and I guess in 3-5 years we'll solve the problem of severity coronary, let's say, significance assessment by CT. Might be in the same time this calcium assessment.
Okay, let's move on with Professor Barbato's lecture for rotablation and rotational atherectomy. An update on 2023, please.
Thank you very much. I have to thank also the speakers that preceded me because they, in a way, anticipated some of the slides I showed, so I can quickly go through some of them. The relevance of the problem was already mentioned a little bit this morning by Robert, informing us that indeed the aging of the patient population is confronting us interventional cardiologists with an elderly patient population in the cath lab as well. As a matter of fact, the proportion of ultra-octogenarians patients has increased, which has a direct consequence in terms of type C lesions that we are treating in the cath lab, as well as in terms of lesions with prevalent calcification. So the two things are tightly related. And this, of course, has a relationship with clinical outcomes. So elderly patients, more comorbidities, more calcium, worse clinical outcome. There is a direct equation there. If we are not carefully preparing them, if we are not carefully treating and managing them. These are just a quick overview on the data that is making my point. Technical challenges were perhaps not listed as they are in this slide, but they were mostly mentioned by my former colleagues, former speakers. The challenges with calcium are related to impaired stent delivery. There is one aspect, by the way, I take the opportunity to mention it now, that rotational atherectomy, but also orbital atherectomy does, which is fracturing the calcified ring where the lesion location, where the lesion is located. But there's another positive aspect that is, in a way, polishing or paving the way to the lesions. It's something difficult to explain, but you know, to get to the segment, the stenotic segment, the bar has to go through a proximal segment. And simply going through that will also facilitate stent delivery to the segment of interest. It can induce polymer ablation. It can induce stent artery expansion. All this is very common. There is a direct relationship, again, between reduced coronary compliance and presence of calcification, which is also explaining why the final stent expansion is suboptimal in these coronary segments. These I can skip. I think it was mentioned by Akiko. And, of course, increased malapposition with that. Stent asymmetry, which again is one of the predictor of suboptimal outcome in these patients, and procedural complications. We have seen a beautiful one in the previous presentation. With final, at the bottom line, is increased target vessel failure. Next, calcified lesions pose diagnostic challenges, and we also discussed about this. The point is that we need to go back and look carefully at the coronary angiogram, because simply looking carefully at the coronary angiogram, we can already identify much better coronary calcification. This was nicely demonstrated by a core lab analysis of angiography of patients that were classified as moderate to severe calcified lesions. So the degree of moderate to severe calcification increases up to 30% simply by looking carefully at the coronary angiogram. So most of those are simply missed because we do not do that often anymore. This, I think, we already saw before in the presentation of Akiko, that intravascular imaging can increase the accuracy in calcium detection from 30 to 40% as seen on the angiogram up to 75–80% as seen with IVUS or OCT. The beauty of CT angiogram we discussed in the presentation of Nia. It can really give us unsurpassed calcium detection. We can quantify the severity of calcium for sure, the volume of calcification, while I'm not 100% sure we can have the detail we look for when we have to perform our PCI. Nevertheless, the results are improving, as Robert was mentioning. This is the corresponding angiogram of the CT you've seen before, and there is no question that there is some calcium there, perhaps a nodule in the distal left main, and there is calcification as well. This is a comparative analysis between calcium on CT and calcium on OCT. This comes from the time I was back in Aalst, and I guess even this slide was prepared by Nia herself. You see that there is a nice correspondence. Yet, we cannot really look into the depth of the calcification with coronary CT. There is still a lot of blooming artifact that is disturbing us. What are the available tools? And here we come to the core of my presentation. We prepared this first consensus document back in 2015 on the use of rotational atherectomy. Why? Because we were around a table of expert operators, and no one was performing this procedure in the same way. Everyone had his own recipe and his own protocol. So at a certain point in time, we realized that if we wanted to have other operators performing this procedure and understanding the potential of this procedure, we should at least standardize it, provide some clear guidance on that. And that's why we came with some main objectives, some indications, and as a matter of fact, contemporary rotational atherectomy use is aiming at plaque modification, which is basically cracking what you need to crack and stop, so prevent doing debulking, in order to smoothen the lumen, disconnect the calcified ring, and facilitate balloon dilatation and stent implantation. That's the contemporary role of rotational atherectomy in most of the lesions. Sometimes you still need to debulk, but most of the times you just need to modify the plaque. This is one clinical case, 87 years old. Again, if you go through the history of these patients and the risk factors, we really see what Robert told us in the beginning. These are complex patients. The risk profile of these patients is indeed high. LV angio, we still like to do it. I don't like to do diagnosis with echocardiography, but that's my personal bias. Preserved left ventricular function. The right coronary artery discloses no angiographically significant lesion. And this is the image you've seen before. So now we have to deal with this patient. We see better the image from this other view. I don't know if the quality is sufficient enough. At least here it's very bright. We decided to do an imaging-guided PCI. Again, the same concept. When you see so much calcium, when you see so much complexity, by the way, left main is involved, threshold to use intravascular imaging is pretty low. We decided to use here OCT because we like to see also through the calcium, and that's the advantage of the OCT. We did a baseline pullback from LAD to the left main, from the circumflex to the left main. And if you follow through, but I have some still frames in the next slide, you see already the complexity of this disease through the whole coronary tree here. Let's look together at the cross-section here. So we have really a compendium of lesions here, starting from superficial circumferential calcification here, neoatherosclerosis in the previous stent implanted in the LAD, deep calcification here, and a beautiful enemy here, a calcified nodule. What imaging is telling us is a wealth of information. It's telling us the landing zone. It tells us whether we need to use one or two standing strategy and which kind of, whether we need aggressive plaque modification technique or not. So this is more or less a summary of the image interpretation. There is certainly an arc of calcium more than 180 degrees. There is a thickness more than 0.5 millimeter, a length more than 5 millimeters, and there is a calcified nodule. So all the ingredients to do good plaque modification with the idea that we already had in mind to do a two-standing strategy. It becomes brighter and brighter on my PC, but there the quality is okay. So we started with rotational atherectomy, sequential rotational atherectomy, left main LAD, 125, 1.5 millimeter bar. We pull back the guide wire, we place the rota wire to the circumflex, and again, left main circumflex, 125, 1.5, stepwise. This is the angiogram post-rotational atherectomy. We performed again OCT to document that indeed we successfully modified the plaque. This is a pullback from circumflex to left main, where you can see lots of fissures and cracks here, as documented also by the steel frames. We were happy. Nevertheless, it's not yet done. We did some additional post-dilatation. At this stage, we placed the two wires, of course, into the two vessels and started stent implantation. So the first one was circ left main, followed by kissing balloon, then another stent from left main to the LAD, tap technique, kissing balloon, pot, control angiogram. If you think the result is perfect, well, never trust angiography, especially in this kind of lesions. Since we had OCT, we checked on it, and OCT showed a sobering feedback in terms of imaging. Some part of the stent were nicely dilated, some others less optimal, and there is certainly a massive extent of malapposition, especially going backward to the left main. Further post-dilatation, bigger balloon, pot, and final OCT pullback that showed an improved result, but the result is never perfect, at least never the way we would like to have. Nevertheless, at a certain point in time, you need to have a compromise and try to accept the best result you can get. This is the pullback. I show you the steel frames. You see, it is a little bit improved malapposition, though there are some struts still malapposed. And that's the final result. That's the angiogram. What are the data? We've got several registries out there. The Euro4C registry is the one that is of our concern because it is run in 19 European centers. What is nice to see that, well, first of all, again, this table describes it all, the kind of patients we are confronted with lots of comorbidities, elderly, multivessel disease, peripheral vascular disease, and these are the results. Radial approach is not any longer a taboo. These procedures, though complex, are performed more and more transradially. We went down in terms of sheath size to 6 French or 7 French maximum. The bars used were often 125, 1.5 millimeter, according to the indications that we should achieve plaque modifications. That is normally done with a ratio of bar to artery of 0.5. And next, these are the rate of in-hospital complications. So despite the complexity of this patient, we are in the range of single-digit in-hospital complication, and this is, let's say, a decent one-year outcome in these patients of all-cause mortality in around 10% of the patients. There is this other Australian registry, which is nice. I like to mention this because it shows how rotational atherectomy, but I would extend this consideration to any kind of plaque modification, can act as risk equalizer. So despite the patient with calcified lesions do present with higher risk features, as you see here on the left side, when you do aggressive plaque modification, then the chance to get similar outcome up to 1 year is quite high. So it's all about preparing the lesion, treating carefully these patients, despite they are unfavored from the beginning in terms of outcome. Randomizing these patients is quite difficult, and that's why you see out there very few randomized clinical trials. We have, of course, those that were led by Abdel Wahab. The Rotaxus trial is the first one. I will go quickly through them. You must know all of them. The bottom line is that I actually learned from those trials is the crossover rate. You know, you can equally perform PCI in this calcified lesion also without rotational atherectomy as long as the balloon expands, as long as the balloon crosses, okay? But the point is that up to 10% of these patients, that is simply not possible. And that's why it is extremely difficult to carefully weight these evidences, simply because they are polluted by the decently higher crossover rate. Prepare calc is more or less along the same line. I'll just go on. Now, the point is that from the time we published the first consensus document, there have been a number of additional tools on the market. Orbital atherectomy is one. The other one is, of course, intravascular lithotripsy. There will be the next talk dedicated on that. And this prompted us to do a new consensus document that is under review now in an international journal that is aiming at providing a practical guidance to the interventional community as to which tool use, as to which device adopt. And we came up, that's actually an abstract from this paper, we came up to a very simple algorithm. As long as the lesion is not crossable, then we have little choices there. We need to use an atherectomy device. But if you can, okay, that's just an example, as you have seen many, I will quickly go through that, of a patient that we treated with rotational atherectomy. But if you cannot cross the lesion, then, if you can cross the lesion, then you should lower down your threshold to use intravascular imaging for the reasons we have told so far. And we should actively look for key determinant of procedural failure. Why? Because we have learned how important it is to estimate the arc of calcium, 270 degrees or more. The length of calcification, Akiko explained us nicely that is an important determinant, as much as the presence of calcified nodules. If you're not in the presence of any of these three features here, then perhaps you can look at non-compliant balloons or cutting balloons. So you can look at balloon-based strategies. Next, This is just an example, a lesion amenable for cutting balloon, and I show you the corresponding IVUS here. That shows a nice superficial located calcification. It's less than 180 degree. And this one we treated with cutting balloon with this IVUS image post-cutting that showed the fracture in the lesion, especially here. It's clear on the first image on the left. Next, the depth of calcification. That was the reason for my question before. There is consensus among these colleagues that prepared the paper that as much as you can see, because it's not always easy to see how deep the calcified lesion is, as much as you can see it and you are dealing with a deep calcified lesions, perhaps atherectomy solutions are not the best one. And that is the place where intravascular lithoplasty would make the difference. This is one example of a calcification that is not really superficial here, that we treated with intravascular lithoplasty with a final angiographic result. By the way, the final stent expansion, for the reasons that were explained before, is always better with intravascular lithoplasty, simply because it cracks in different places of the coronary segment, unlike with the atherectomy solution. And if the calcium is circumferential and superficial, then the call is for atherectomy devices. That's one other example here of a tortuous calcified lesions. We managed with some fortune to do intravascular imaging here, IVUS, where you see a superficial and circumferential calcification treated with rotational atherectomy. By the way, it's amazing how this bar, when it is carefully handled, can travel through these calcified and tortuous coronary segments. This is the IVUS image afterward, and I guess the final angiographic result. Now, this is my conclusive slide. In 2023, I was asked to give you some updates. That is the update I can share with you. There is this new consensus document coming up, aiming at facilitating implementation of diagnostic tool and to address the existing heterogeneity in treatment adoption. Here we proposed a reasoned stepwise approach to complex calcified coronary stenosis that is going, that's our hope, to optimize resource utilization while providing the best therapy to the given patient and to the given lesion. Thank you very much.
Thank you, Emanuele, for your excellent lecture. So now the lecture is open for discussion or comments. I just want to ask you, what's your preference, orbital or rotablation? And in which cases?
Yeah, well, my answer is easy. I have limited experience with orbital, so my preference goes also for personal experience to rotational atherectomy, but I don't want to escape your question. There are certainly settings where my preference would go to rotational atherectomy. For example, uncrossable lesion. Simply because we know that the bar of the rotablator is such to have diamonds at the tip, and that would exert the abrading effect really forward-looking, while with orbital atherectomy, the diamonds are circumferential. So they are, for example, orbital atherectomy is beautiful if you have long lesions, long calcified lesions and tortuous segments, simply because it can ablate going forward and going backward. So you have pros and cons of both tools. Having said that, of course, you have to make a choice. I don't think anyone in the room, perhaps our friend from Cleveland Clinic, can afford to have both devices, but certainly not at our latitude. You have to make a choice and decide whether to invest on rotational atherectomy or orbital atherectomy. But whatever you choose, I think one of these two devices needs to be complemented, in my opinion, also with intravascular lithoplasty. Those two tools need to be integrated. You cannot have only orbital or only IVL, because you will be confronted one day with a case where you cannot make it with either or of the devices.
Thank you.
Do you think? Yes?
I have some experience, 1 year experience on orbital atherectomy. Of course, it's available in my country, but 3 times more expensive than rotational one. So therefore, we are forced to really base our decision on intravascular imaging. And I can tell you that the biggest artery the more superficial, more superficial is, and with difficulties of say associated with the with the anatomy on the way to the lesion. It's easy to use orbital. And what is also very very often found by us, that tortuosity of the vessel, it's much better to approach the lesion with orbital as well. Less time you need additional intravascular lithotripsy after orbital than after rotablation. But when you have very deep, diffuse circumferential calcification, definitely rotablation has a superior for such a lesion. Unfortunately, sometimes we have to add intravascular lithotripsy. It costs as well.
Costs a fortune.
Yes. Do you think that we are now at the moment moving to the rotatripsy strategy as a basic? I mean, or
it's not something it's not something affordable. Although I would like it very much, I don't think we can afford this on a systematic basis. There will happen cases, as Robert was mentioning, where you are forced to use it. You know, we always learned that after rotational atherectomy, I'm not saying the procedure starts, but almost, because it's not yet over. You do rotablation, but then you still have to modify the plaque. And we have an intermediate step with non-cutting, with non-compliant balloon. That is the moment we realized that rota was not just enough. And no matter how big the bar was, as it was mentioned before, there is always a biased atherectomy action there. It's not a circumferential plaque modification exerted by the atherectomy devices. So you have to bear this in mind. Sometimes it's just not sufficient, and these are the cases where you need to have your IVL balloon ready, but not on a systematic basis. I wouldn't advocate that.
Yes, maybe the key word is routine.
Yeah.
We should do everything on the selected basis, on the case-based basis. And another point is all the randomized studies with the rotablation, starting from Rotaxus, which, as I remember, this is the first randomized study with the rota versus balloon. Actually, they demonstrated equal efficacy, but the crossover is between 12.5% to 16% in prepare cow, which means that, let's say, 1 in 8 patients could not be treated without rotablation.
Correct.
And doing randomized study in those cohorts is a little bit nonsense. So the point is regarding the recommendation class, because in the last guideline from 2018, there is no recommendation about the rotablation.
It was taken out, you're right.
It was taken out, and the last, it was in 2014, for the last time we have some recommendation.
Totally
there
right.
is still recommendation in the American guidelines. This is actually the point where, because the guidelines from the certain point of view start to be very important when the legal issues come.
Sure. Well, you're totally right. It was taken out. You know, guidelines are just reflecting what the current evidences are telling. And of course, if the evidences are weak, then you will find less mention about a certain therapy in the guidelines. They are nothing. It's not a law. Guidelines are just, let's say, a summary of the data that are available out there. Nevertheless, in the guidelines, we find lots of 1C recommendation. C means zero evidence. 1 means stronger recommendation. So I wonder whether it's just a matter of consensus at the end. Lots of recommendations. We can list many of them. So I wonder whether one of these days we should give a 1C recommendation to plaque modification devices. I don't want to put a name, otherwise it seems that we do commercial advertising here, but it's not the point. The point is that we can simply not do certain sort of procedures without. It's like the parachute paradox. Would you jump from an airplane without a parachute? There is no evidence there, no randomized trial that stands. Nevertheless, it's a 1C indication, having a parachute before jumping from an airplane.
Emmanuel, if we look at the history and comparison between oncology and cardiology, we see the same problem. Oncology, assessing the therapies, drugs, they use different endpoints. Cardiology, let's say, is accustomed to use the most hardest endpoints. And
mortality.
then, therefore, we have this power of recommendation classes based on let's say, randomized trials, where we, by the way, we have very selected group of patients, not, let's say, every coming to our cath lab. So, by the way, we created such a situations, and a lot of things which we used to do is just off record, off label, sorry.
Totally right. But let's be also honest, Robert, these endpoints are also artificially created and customed to the kind of study you are designing. Sometimes we even set as an endpoint recurrent angina, which is the least objective endpoint that you can ever report. So it all depends. It all depends from the study design and from the endpoint that you want to achieve.
Okay, thank you.
Thank you.
Let's go. Thank you very much.
We have the lecture of Professor Unghi on record. Can we switch it on?
Good afternoon. My name is Imre Unghi. I'm from Hungary, and first of all, I would like to thank the directors and the organizers of the 11th BBC meeting for the kind invitation. I'm sorry that this year I will give this presentation online and I cannot be with you in person in Sofia. My task is today to speak about intravascular lithotripsy, the youngest treatment modality of calcified lesions, coronaries and peripherals as well. We have known for a long time that coronary calcification is one of the most feared enemies of interventional cardiologists, as it was expressed already more than 50 years ago by Andreas Grünzig in one of his presentations. Not only the problem old, but also the attempts to deal with this problem. There are several conventional opportunities to treat the calcified vessels, like the high-pressure non-compliant balloons, the focus-forced balloons as the cutting and scoring balloons, and also atherectomy devices, mechanical atherectomy devices, like the rotational and orbital atherectomy, and also thermal ablation by excimer laser. The working mechanism of these devices is either high-pressure tissue compression or tissue debulking. Due to the intense effect exerted on the vessel wall by these devices, the complication rate is not negligible. And the potential complications are distal embolization, dissection, and perforation. For some years, there is an alternative treatment of calcified vessels with a completely different and unique principle. This is the intravascular lithotripsy with subintimal disruption of the calcium. So subintimal is the important part of this principle, without removal of the plaque material and without incision of the intima. The working principle of intravascular lithotripsy is that it's a transformation of electrical energy into mechanical energy transmitted through sonic waves from the balloon to the vessel wall. Intravascular lithotripsy does not affect the integrity of the intima and the other parts of the soft tissues of the vessel, but if hits into a rigid material like calcification, it breaks it into pieces. The hardware for intravascular lithotripsy is quite simple. There is a portable generator, it's a battery-powered generator, which is connected via connector cable to the 6 French compatible monorail balloon, which equipped with emitters. I will show it later. The connector cable contains an activation button for the comfort of the operator and for single-use action. The structure of the shockwave balloon looks on the upper image of this slide. This is a longitudinal section, and we can see that between the 2 radiopaque markers of the balloon, which is 12 millimeter long, there are 2 electrical emitters on the shaft of the balloon. The mechanism is that electrical discharge generated by high voltage, several thousand volts, and it vaporizes the fluid, creating rapidly expanding bubbles. These exploding bubbles generate waves, sonic waves, high energy sonic waves actually, that travel through soft tissue but cracks calcium within the vessel wall. After this modification, calcium modification treatment, the compliance of the vessel will increase and the balloon dilates the vessel at low pressure with less tissue injury. The steps of the procedure. The first is size selection of the shockwave balloon. It's a little bit more important than with normal balloon angioplasty because it's really important to have a perfect position between the balloon and the vessel wall. Otherwise, if there is a gap, a part of the energy would have lost to the blood of the coronaries, and it would decrease the efficacy of the lithotripsy. After connecting the generator to the balloon, there is a low pressure inflation of the balloon at 4 atmospheres, and then activation of the emitters. There are 10 pulses delivered at the frequency of 1 pulse per second, then it automatically stops. After that, the pressure of the balloon, inflation pressure, should be increased to 6 atmospheres for dilatation and for confirmation of the expansion. I mentioned already that it's a 12 millimeter long, so a short balloon. Usually the lesions are longer, so the treatment can be repeated in overlapping segments, and the maximum capacity of the balloon is 80 pulses per catheter. The advantages of the intravascular lithotripsy to atheroablative devices. It's very easy to use. It's a POBA-like procedure. I think it's an important point because the short learning curve is very attractive, usually for the operators. It acts subintimally, so the chance of embolization is significantly less. The energy delivery is circumferential, so in case of tortuous calcified vessels, the guide wire bias does not decrease the efficacy. We know that in case of rotablation, it's a significant problem potentially. The balloon pressure is low, the dilation pressure is low, so the tissue injury is less, which could be important for the long-term outcome of the procedure. In case of bifurcation calcified lesions, the side branch protective wire can be kept inside continuously, so we don't lose the opportunity to save the side branch in case of any sudden occlusion. And of course, if the side branch treatment is necessary, again, the main branch wire is inside continuously. Again, it's a problem, it's a potential problem with rotablation. There are some drawbacks of intravascular lithotripsy. As I already mentioned, it's a bulky balloon. The diameter of the emitters determines the crossing profile. And of course, it's a stiffer balloon than the normal semi-compliant balloons. So the deliverability is significantly less than the normal and even that of the non-compliant balloons. The next potential drawback that in extreme cases with big calcium burden is possible that even the maximum 80 pulses is insufficient for an effective treatment. In this case, we have to turn to an alternative modality. Balloon rupture might happen, it's infrequent, and it's not a specific complication of the lithotripsy. It might happen in every angioplasties. There can be incomplete apposition. I mentioned that the maximum size of the shock wave, the coronary shock wave balloons, is 4 millimeter. So in bigger vessels, it might be incomplete apposition and less efficacy of the treatment. So for left main, for example, or big right coronary, it can be a problem. In case of very complex anatomy, again, the incomplete apposition can be the case, and it might result less efficacy. There is an interesting side effect of the lithotripsy treatment. On this ECG on the right side, looks that from the third cardiac cycle, the morphology of the QRS changed, and also the systolic blood pressure decreased. So it's a ventricular capture, series of ventricular capture beats generated by the lithotripsy pulse. It works like an asynchronous pacemaker in this case, and the explanation is a mechanoelectrical coupling to the conduction system. Theoretically, due to an R-on-T mechanism, it can be proarrhythmic, although it was no reported malignant ventricular tachyarrhythmia during lithotripsy treatment. But anyway, it's a potential problem, and maybe in the future it might require an ECG gated system introduction. The biggest problem and the most frequent problem is definitely the deliverability and the crossability difficulties. If the shockwave balloon is uncrossable, we can follow some steps to deal with this problem. If we replace the shockwave to a low profile 1.0, 1.5 millimeter balloon, we can check the crossability of the lesion. If it's still uncrossable with these small balloons, probably shockwave treatment is impossible, so we have to turn to rotational atherectomy or some other kind of treatments. If these small balloons crossed, we should do a pre-dilation with them, and after that to change to a 2 millimeter balloon, and again dilation with the 2 millimeter balloon. Probably the shock wave can be introduced already after this predilation, and if not, we can get down with a guide extension catheter with inch-form technique with this 2 mm balloon, and after that we can introduce the shock wave into the lumen of the guide extension catheter. For this last step, we have to take into consideration the diameter compatibility question between the guide liner and the shock wave. In this table, we can see that with a 5 French guide liner, it's now possible to use a 3, 5, or 4 millimeter shock wave balloon because of the large profile. Only the 2.5 millimeter shock wave is compatible with the 5 French guide liner. But from 5.5 French guide liner, all of the coronary shock wave balloons are okay. There were some clinical trials investigating the efficacy and safety of the lithotripsy treatments. The DISRUPT CAD-1 trial was the pilot trial with 60 patients, and it proved a high device success with 0 procedural complications and with reasonably low MACE rate. The DISRUPT CAD-2 trial with more patients, it was an ID trial for FDA approval, practically reproduced the results, the clinical outcome results of the CAD-1 trial. In the CAD-3 trial with more patients, there was already an OCT sub-study in 100 patients, and it confirmed the safety of the treatment, and the OCT images demonstrated longitudinal and circumferential calcium fractures, resulting in better vessel compliance, large stent area, and excellent stent expansion. The pooled results of these 3 DISRUPT trials is available in more than 600 patients, and it demonstrated that although the vast majority of the patient had severe calcification, the procedural and clinical success was high with very low major complication rate. Due to these favorable results of the CAD trials, the intravascular lithotripsy got into the flowchart of the algorithmic approach, the latest algorithmic approach for management of calcified coronaries. It was published in the last year, and it looks that the suggestion for the primary treatment is determined by the intravascular imaging. Intravascular lithotripsy is suggested as the primary treatment in focal lesions, in bifurcation lesions with both branches requiring calcium modification, in thrombotic calcified lesion, and in underexpanded stents in presence of calcium outside of the stent. Additionally, as a secondary treatment, it is recommended if after atteroablative methods, the balloon cannot be reached a full expansion. So if after a rotablation or orbital atherectomy, in this case, we can apply lithotripsy as well. I would present a multivessel calcified coronary disease patient case just to demonstrate the effect of lithotripsy. This gentleman was 67 years old with a high grade of angina with typical risk factors and severe chronic obstructive pulmonary disease. The left ventricular ejection fraction was good. There was a severe calcified triple vessel disease. Finally, the decision of the heart team was angioplasty because of the severe COPD and in part by the reluctance of the patient to CABG operation. We can see that there are sequential calcified lesions in the big right coronary. There is a focal lesion in the ostium, critical lesion in the ostium of the LAD, in the ostium of the big diagonal branch, and a critical lesion on the circumflex as well. We started the procedure with the right coronary. This is a lithotripsy of the distal lesion with a 3.5 millimeter shock wave balloon. It looks that we had problems with the deliverability of the shock wave, so we used the guide extension catheter for this. With a repeated overlapping shock wave treatment, we can cover both of the lesions with a big and long stent with, I think, quite good result. After that, we did a normal predilation, normal balloon predilation in the circumflex. It could be done. It was not so much calcified, and the stent implantation in the circumflex. After that, we did a lithotripsy in the ostial calcified lesion of the left, the LAD. After that, we had to treat the bifurcation lesion of the LAD diagonal. Finally, we decided to do a DK crush stenting of this bifurcation. This is the positioning on the left side. We can see the positioning of the diagonal stent with a crushing balloon in the LAD. And on the right angiogram, a long stent positioning in the LAD covering the distal and the ostial lesions and protruding into the left main. The final result was, I think, acceptable if we take into consideration that it was a multivessel complex calcified disease and procedure. In this presentation, I would not attach the peripheral intravascular lithotripsy, although it has an extensive literature and clinical experience, but due to the limited time frame, I don't go into the details. But I would present to you an interesting case. I think it's an interesting case. This patient I received this case from a friend of me who is a master of interventional radiology, and he found this patient with a calcified instant restenosis of the common carotid artery, and the result of the intervention was excellent. And with this short movie, we can prove that it was really an intravascular lithotripsy. It can be seen, and probably it can be heard as well, that it was a very effective treatment. Of course, it's now an off-label application of shock wave balloons, but there was no any complication, and I think that in the future, lithotripsy can go into the treatment of carotid disease as well. As a conclusion, I would mention that intravascular lithotripsy combines the calcium disrupting capability with the ease of use of balloon catheters. The clinical studies support the effectiveness with a low rate of major complications. And of course, we need the result of some ongoing trials and further registry results to determine the final place of intravascular lithotripsy in the treatment of severely calcified coronaries and peripheral vessels. Thank you for your attention.
I would like to thank Dr. Ungi for this excellent presentation. He's online. Hello, Imre. Nice to see you.
Nice to see you again after several years.
Yes. So we are here with Professor Barbato, Dr. Zheleva, Professor Gatsov, and everybody in the audience. How frequently you use intravascular lithotripsy in your practice? Let's say, okay, let's not generalize, but in calcified lesions, let's say so.
Yes, yes, of course. Thank you for this. It's one of the most important questions, actually, in practical respect. I think that the full case number of our center is a little bit over 50. I personally used it in 10 to 20 cases, so not really frequently, mostly due to financial restrictions. There is a funny reimbursement of lithotripsy in Hungary now. The patient have to apply for how to say personal fairness for the insurance fund, and if of course with the enclosures of the medical documentation, and if the insurance fund agrees, we can do the procedure and it's reimbursed, but it's not a everyday situation. So that's my experience.
Okay.
Hello, Imre. It's Eva.
Hello, Eva.
Thank you for the presentation. In our center, thank you to Valery, we have the luck to work with Shockwave also, and we have around maybe 25 cases. I think that the great importance of intravascular lithotripsy for the largest vessels. We have some cases when we rotablated with the burrs above 1.75. I've never used 2.5. I don't know if anyone have used 2.5 burr. But even though we couldn't crack the circumferential calcium of vessels around 4 millimeters, and then the intravascular balloons, lithotripsy balloon, solve our problems. And I think that the role of intravascular lithotripsy is very important for these large vessels with thick circumferential calcium, and when rotablation couldn't work.
Yeah. Thank you, Eva. I personally agree with you, and one of my slides presented this this flow chart, this algorithmic approach to the calcified lesions, and also there it was mentioned that if after rotational atherectomy or orbital atherectomy you cannot reach result enough by the expansion of the balloon, non-compliant balloon, it can be an additional treatment. Of course, as Emmanuel mentioned in his presentation, we cannot afford this combination of the treatments regularly, but in special cases it can be a good solution, I think.
Okay. Other questions, comments? Valery?
Hi, Imre.
Hi,
nice to see you, and thanks for your contribution, really, to the scientific part. Just as a comment, I would say that intravascular lithotripsy, in a way, should be, we should have it as a bailout method, because what Eva says is one of the cases in which we were not able to deal with such a serious calcified lesion, and it was really without any other options finally. And if we did not have this lithotripsy, probably the result was going to be not that good. Another option is, as Kiku mentioned, and we have several experience, this is well dilated stents, because very calcified lesions. And this is, we have 3 cases in which lithotripsy was again a bailout situation, because one of the patients has several times attempts to open really a very suboptimally implanted stent, and the lithotripsy helps us very easily to solve the problem and let's say solve the problem of this lesion and of this patient, which was hanging around 1.5 years. So all these methods, they're complementary, and probably a huge cath lab which is having a big volume of patients and addressing complex patients should have it on site, because it's important.
Yeah,
Okay.
I agree.
Yes, Imre?
So I would just mention that I would focus on the points what Valerie mentioned, the undilatable stents in calcified lesions or compressed stent by the calcium. We know that maybe the only opportunity up to the appearance of lithotripsy was laser for this, but I think that both the user-friendly nature of lithotripsy and maybe also the efficacy and the easiness of use is higher for lithotripsy than with laser. There are much less laser devices in the cath labs than lithotripsy now.
Emanuele, have a comment?
Yes, I carefully listened to what Valerie and Imre just mentioned. Valerie was telling about using intravascular lithotripsy as a bailout device. And Imre just mentioned the ease of use of this device. I want to start from these two statements to just underscore the statements we did at the beginning. We are dealing with complex patients, we are dealing with complex procedures. In the very beginning, when intravascular lithotripsy was launched, it was perceived as a shortcut to treat these complex patients, skipping all the learning curve experienced operators like the ones in the room, like Imre and any others, arrived to the use of lithoplasty. And this device was given in the hands of less experienced operators who thought they could treat them all just with this balloon-based strategy, which is easy to use, for sure. It is attractive because in a way it gives us a toy that we are comfortable with. We are used always to dilate with a balloon and to implant a stent, but we should never forget that we are treating a complex patient, and these devices cannot fit all the kind of situations. And we should get this device as one of the tools in the portfolio of tools and techniques to manage these complex patients. Because if the message that comes across is this is a device that is replacing all the others, you don't need of anything else but just this balloon-based strategy, I don't think we are doing well our job in educating younger colleagues. I don't know what Imre thinks about this.
Absolutely agree with you, Emmanuel. I just have some personal communication from the company data that there is an extremely high increase of use of lithotripsy is the present state of statistics, especially in countries where there is any limitation of financial limitation of the device use. So probably because of the approach you mentioned, now in some countries, in some cath labs, there is an overuse of lithotripsy just because it's easy. But the proper approach, what you mentioned, I completely agree with you, to be able to treat a complex lesion, not a device. So I think that still there is some time when the this device find its place, in the proper place in the calcified lesion treatment.
I fully agree with Professor Barbato, because in most of the cases, our experience, in order to get to the place that we want to use the lithotripsy balloon, in more than 50% we use rotablation to pave the way, as you excellently mentioned in your lecture.
Okay, so thank you, Imre. Please stay with us because we are delayed, let's say 30 minutes, and George Sianos is already online, but I propose to have a 15 minutes break, just because I see that there is a severe cerebral hypoxemia in the audience and hypoglycemia. So I propose 15 minutes break. Just there are some beverages outside. Just take a coffee, and after 15 minutes, I'm waiting for everybody here. Thank you.